Thank you, Monica. I wanted just to tell you a little bit about TREATme. That's the European Network of Individualized Psychotherapy for young people with mental disorders. And TREATme was a cost action, and the funding period was from March 2017 to September 2021. And COST, that is the longest running European framework supporting transnational cooperation among researchers, engineers, and scholars across Europe. And more than 60 members from 30 European countries actually have signed up for the post-action collaboration after the funding period was ended. And TREATme objectives, that is to change and disseminate specific knowledge about important factors that will improve outcome in different youth psychotherapy modes, and increase knowledge about what works for whom and how in youth psychotherapy. And we have working groups, and they collaborate on systematic reviews. And one working group is working on specific markers or moderators, and one on mechanisms of change or mediators, and one on age customized process and treatment measures. And we also have one working group focusing on age customized research designs. And actually we have put quite an effort into dissemination, and we had an extensive use of dissemination platforms during the action, and that was actually also acknowledged in the post-action cost evaluations. And the management structure of TREATme is that we have a management committee, and that actually includes all network members. And we have annual meetings, and in order to connect researchers in youth psychotherapy, share research results from the network based on data collected during the funding period, and present research that springs from the network. And as mentioned, we have 4 working groups, and they're all still collaborating and working. And we have a core group with monthly digital meetings. And we are very, very happy to collaborate with CAFTR. And we have one member at present, that's me, as the chair of TREATme, that is working and collaborating directly with the CAFTR and participates in the CAFTR steering committee meetings. So I will not say anything more. We have a webpage, so please access the webpage. I can put the link in the chat, and now we will hear more substantial research from the network.
Okay, thank you, Randi, for presenting TREATme. So we'll hop straight to the presentation. Let's see if I can share the screen. Do you see it now?
Yes, we can see it. It's not still not in presenter mode, but we can see the presentation.
Yeah. How about now?
It's still the same.
Still the same. Okay,
yeah.
But let's still go on, because we had these problems with Zoom, so let's not waste time for that. If you can see still the presentation, we'll probably handle it like this. So hello everybody, I'm Vera Gergov. I'm from Finland. I'm the vice chair of TREATme. I work part-time for the University of Helsinki, and then most, or actually full-time for the Finnish Psychological Association, and I've been member of TREATme since the beginning, and also part of the core group and conducting some parts of the dissemination. But today we're going to talk a little bit on the work of the working group 1, so the group that's doing research on predictors and moderators of treatment outcomes. And this systematic review that I'm going to present today is our systematic review that was published last year about the sociodemographic predictors. So as you can see, there's a large group also in the working group 1. I think there's like 18 authors in the paper, and there are a couple of more people who have joined the working group 1 after that. And we've, of course, lost also some members, but more or less there are like 15, 16 active members still in our working group. What was the aim of the present study? We wanted to do like a very comprehensive overview of the predictors and moderators overall on the young people with mental disorders across treatment modalities. So this is just one part of the research that we've been doing. We have multiple systematic reviews coming out from the working group 1. There's one going to be the next one probably on psychological predictors, then also clinical and family related predictors, and this one is on the sociodemographic variables. We decided that this will be the first one that will start, because mostly what we know on predictors is that sociodemographic predictors are kind of one of the most researched predictors in the psychotherapeutic world. We, of course, also registered in Prospero the full protocol. So if you want to see the full scale what we're doing, you can have a look also on that publication. But when we started doing the systematic review, of course, you first have to set the study selection criteria. So we started with the PICO strategy, thinking what's the population, intervention, outcomes and study designs, what we want to have a look in the systematic review. So we set the inclusion and exclusion criteria. We decided the databases that we will use for the review. It was PubMed and PsycInfo. And the last search, we did a couple of kind of reviews on the search, but the latest was done in April 21, so basically 3 years ago. And it took quite a while to write the reviews, and we probably need to do some more updates for the upcoming reviews. But so as you can see, the criteria is quite wide. So first, the population, what we were looking at is the adolescents and young people. The age criteria was like from 13 to 29, and then we gave like one extra years on both ends, so from 12 to 30. Participants who have specific mental disorders that we also wanted to describe and put the keywords on that. And then the interventions, we wanted to be quite wide with psychotherapeutic interventions. So there's also kind of psychosocial treatments that could be discussed. Are they psychotherapy, or how do you kind of put them in specific parts? Because in different parts, even in different countries in Europe, you kind of define psychotherapy a little bit differently. So we wanted to be very, very inclusive with the interventions that we will be including in the review. And then the comparison group, we decided that there's not going to be any exclusion criteria. So we didn't want just RCT studies or studies that have to have a comparison group, but wanted to include also studies that are just looking at one group and one intervention. And then about the outcomes, the important thing was that we have a pre and post measure, and of course that the outcomes are related to the disorders or the problems that the participants are dealing with, but didn't want to set any specific outcomes. So basically, more or less, any kind of clinically relevant outcomes were welcomed if the study is like a clinical outcome trial from different types. So we didn't want to include any kind of books or dissertations, and also case studies that have less than 10 cases, or that the results are not reported in like a group level. We decided to exclude those ones, but to be quite wide with the clinical outcome trials, to include also naturalistic settings and so on. And about the language, yeah?
I'm sorry to interrupt you, but I think when you changed to presenter to the other mode, we are only able to see the first slide, the one of the title. So I didn't know if you were changing, but I think you have changed the slides. Maybe you want. Now we are, yes, okay, great. I didn't want to interrupt you, but now we are.
Good that you interrupted, because
Great,
I did want to change the slides, but it's okay. You'll hop in from now. So just showing like how wide was the PICO strategy on how to define the population and the intervention, and then of course also the outcomes and study designs and so on. So how did we build kind of looking at the PICO strategy, the inclusion and exclusion criteria. So you didn't miss much more without seeing the slides yet. And then we did have some specific choices that we discussed quite a lot on how to deal with that. So would we do the search by disorder groups, or do we try to find different types of predictors, or how do we build kind of the search strings when you put them into the databases? And we did decide to do the searches by disorder groups. So we did 10 different searches. All searches had the same string for treatments, as you saw, the string and age and study type, and then separate disorder specific string. And we did that 10 times, so 10 searches, and then combined all that. And that was because we didn't want to make any pre-assumptions on what kind of predictors will we find. So if you put keywords to the search on predictors or define different predictors, then you already might exclude some studies that are looking at totally some other types of predictors. So we did it, let's say, the hard way and did quite wide search, doing it by disorder groups, and then hand-picking the predictors. I will show you that a little later on the screening process. We did end up, when removing the duplicates, with more than 17,000 papers to screen. So that's just to give you an impression, like on the workload that we had in the group, starting to screen all these papers. And we did have a stepwise screening process, looking at like pairwise. We always had like 2 raters for specific disorder group, comparing their screening ratings, so to include or exclude a paper. First, did the title and abstract screening. We combined them first. We thought that we'll just do a title one and then go to the abstract, but in the end decided to combine the step 1 and 2 and have a look if the disorder is there, what we're looking for, if the intervention is psychotherapeutic intervention, if the study type fits, participants are the right age, and at least the title and abstract had to be in English. And then for each step, if you're not sure if the paper should be included or excluded, then you always include the paper. So exclude only if you're 100% sure that some of the criteria is not fitting in. And then you go to the full text screening, so the 3rd step, and have a little bit deeper look if the criteria from the step 1 and 2 are actually there, and then look a little bit more closely on participants' clinical status and the assessment points and so on. And after the 3rd step, we actually, at least hopefully, had all possible outcome studies for different disorder groups among adolescents and young adults. So that also gives us the opportunity to do systematic reviews, not just on the predictors and moderators, but also on the effectiveness and outcomes, and also by disorder group if we want to. And we have published some papers for specific disorders for the effectiveness. So this kind of gives us also a lot more flexibility, so we can do quite a lot of different types of reviews. But the step for this study, of course, was kind of manual selection of the predictor and moderator studies. So after step 3, we had all outcome studies. Then from the outcome studies, we selected the ones that had done some predictor moderator analyses, so to see what kind of variables are predicting the outcomes. And this is yet the Prisma chart. And the last step, you also if you exclude papers, you need to have a reason why you exclude. So to be a little bit more specific. And as you can see, we actually found 291 papers on predictors and moderators. And then from those papers, 114 did report sociodemographic predictors. So they are included in this systematic reviews. And the rest of the papers will be included in the rest of the reviews that are still coming. And from all 114 papers, we of course extracted the data, so some basic information on the article, some information on the sample, and then about the predictors, moderators, what kind of predictors there are, if it's a predictor or a moderator, if it was found significant or not. And then we also did for all the included papers a risk of bias assessment by MM8AT tool just to have some kind of idea on the quality of the studies that are included in the systematic review. So the MM8 tool is for the quality review. Okay, and what did we find from this 114 studies? We found 18 different sociodemographic predictors, a total of 287 predictor analyses. So there was, in many of the papers, they did report maybe 2 or even more sociodemographic predictors. And also for the predictors, there was in many papers, there was different outcomes also. So the predictor was analyzed several times and so on. And from the 114 studies, 90 were RCTs and 24 were non-RCT studies. And as you can see, our age range was quite wide. We did get some critique from the reviewers on that from 12 to 30, that it's very different to treat a 12-year-old than a 29-year-old. So in the protocol, we also stated that we will do kind of separate analyses for adolescents and separate analyses for young adults. But as you can see, actually, most of the participants in this, that from the studies that were included, were actually adolescents. So there was very little participants over the year 20 years old. So we didn't find it very meaningful to do a separate analysis for the kind of the young adult population, because most of them were under 20-year-olds that were included in this. And also, as age is one of the most studied predictors, we are kind of taking into account also age as a predictor in the review. And as you can see, age, gender, ethnicity were the most studied predictors. And there was quite a lot of predictors that were present only in less than 10 studies, or even just in an individual study. So the variety of sociodemographic predictors that we found was quite wide on that. And if you look at the significance of predictors, so there was 287 predictor analyses in these papers. And as you can see, very little of them were actually significant or even mixed. And mixed means that the predictor was significant for some outcomes in the study, but for other outcomes it wasn't significant. So it was kind of a mixed study that it was predicting something, but maybe not all outcomes. The disorder groups that had most predictor and moderator studies were substance use disorders, mood disorders, and eating disorders. And again, we had several disorder groups that had very little actually predictor or moderator studies, even a little bit surprising. You would assume, for example, for anxiety disorders, that there would be a lot of predictor studies, but surprisingly, very little actually. Actually, only 11 predictor moderator analyses were found in the anxiety group. Also ADHD, psychosis, autism, personality disorders, very little predictor studies. And keep in mind that these are adolescents and young adults, so there might be more predictor studies that are concerning adults in a wider age group. But if you look specifically at adolescents and young adults, there's surprisingly little predictor studies, even for sociodemographic predictors. And here we also had a table. I won't go through it, but you can see by disorder groups and by all the 18 predictors that what was the findings, like significant or non-significant for the predictors. But overall, the results actually revealed that none of the sociodemographic predictors were clearly significant. So the analyses found the sociodemographic predictors not to be significant predictors of the outcomes. And even the 25% of all the studies that did report some significant predictors, there was still mixed findings also in those. So some of the studies reported, for example, that older adolescents benefit more from psychotherapy, and other studies showed that younger adolescents would benefit more. So they were quite mixed also, the results, even for the predictors that were significant. So basically what we did find, even tentative findings, was 3 things that should be kept in mind. So history of traumatic events. There was different traumatic events that were combined for one variable, may predict poorer treatment outcomes. So if a patient has a history of traumatic events, it could predict poorer treatment outcomes. And also belonging to an ethnic minority group may predict poorer outcomes. And then there are some potential variables that we need to do more research on that could be significant predictors, that social support, forensic history, a source for referral to treatment if the adolescents was kind of referred there by themselves or with a, like who did the referral for the treatment. And interestingly, for substance use disorders, we did find also some more variables that could be important, but these results were found only for SUD. So for other disorders, you couldn't find these predictors to be significant. So for SUD, males may have better treatment outcomes than females, and higher education could predict better outcomes. And also some potential predictors may be the social support and accommodation status, so the living situation of the patient. And then if we look a little bit on the quality of the studies that were included in the review, as said, there was 90 RCT studies. Most of them were conducted quite nicely, so reporting on the randomization process and comparable groups at baseline. But as you can see there's quite a lot of adolescents, young adults that do not complete the intervention. So there's not complete outcome data in the end of treatment, or that the participants are not adhering the interventions. And also, of course, it's a little bit difficult to do kind of blinding of the outcome assessors. I could talk on that a long time. I won't go there for now. That how do you assure kind of that the assessment is blinded, even though you can't really blind it for psychotherapy. And then also the quality of the non-RCT studies. It was good that all participants were representatives of the target population that were included, and the measurements were appropriate. And also there you can find that the outcome data was not complete at the end of treatment, even though most of the interventions were administered as intended. And then there was also not enough maybe reporting of the possible co-founders that are interacting with the predictors and moderators. So some quality issues on that sense. And if going to the discussion part, what we need to highlight, of course, is that findings are highly tentative because there are so little research overall done, and very little even from that research is pointing to a direction that sociodemographic predictors would be relevant at all. And that's actually a finding that's in line with most of previous findings, that sociodemographic predictors are not very good predictors of treatment outcomes. So it is difficult, if not even impossible, to predict from the sociodemographic variables that who would benefit more from what kind of treatment. But the thing was also what we did notice, that the studies were really difficult to compare. There was a lot of methodological issues, mixed results, small sample sizes, and most of the studies were lacking like specific hypotheses about the predictor outcome relationships. So there was kind of sense of fishing results. So you first do an outcome study, and then it comes to your mind that, oh, let's see what are the predictors, and then just test everything without kind of designing a predictor study or having like hypothesis on what could be the possible predictors. And what we could conclude from this, the main conclusion is basically that forming guidelines on performing predictor and moderator studies is very, very necessary. So we would need actually to do this to kind of have some kind of guidelines what you need to do when you are planning to do a predictor study. We need to have sample sizes that can actually answer the questions, and the study designs on that, and also there was some issues with the statistical analyses and even testing the same predictors, moderators across studies is not very widely kind of, we don't have an agreement what are the predictors that should be tested. And then also one thing that we were thinking, that sociodemographic predictors could possibly actually be more important predictors of the access to treatment. So for example, adolescents from different socioeconomic groups or different ethnic groups might not even get to the treatment. So if we look only at the patients who are involved in the treatment, maybe the sociodemographic variables are not that important anymore, but we don't see the ones who didn't even get to the services. So probably sociodemographic predictors are more significant on the treatment access, predicting like who's gonna get to the treatment. And then, of course, some strengths and limitations on the study. I won't go deeply in there to give more time to Sonja, but of course the transdiagnostic approach was quite good, like strength of the study, even though it was very hard work and could also cause some limitations, like the possible loss of some studies and so on. And we didn't do a meta-analysis. It was difficult because the papers or the studies were so different. We did think about doing maybe a smaller set of papers and doing meta-analysis, but we had so wide range of the predictors and so little studies that in the end we decided just to do the systematic review and not to meta-analysis. Actually, we did decide that already beforehand, because we kind of knew that this is going to be the situation, but we reconsidered this also at the later stage, but kept this approach or doing just a systematic review. Okay, thank you. That was our study. Maybe we go directly to Sonja and then discuss it and take some questions in the end, or what do you think?
Thank you. Thank you, Vera. Check. Okay. Do you see the presentation, right? Or the same as Vera?
Same as Vera. Same as Vera.
Okay, so this
we
is
can
something.
See it. Yeah, I think
Okay.
something with Zoom.
Okay, then I will. Do you see when I change the slide or not?
Yes, if you press, yeah.
Okay, thank you. So my name is Sonja Protić. Originally, I'm coming from Serbia. I was a partner from Institute of Criminological and Sociological Research in Serbia. Now I'm professor at University of Applied Science in Darmstadt. And I was part of TREATme working group 2, dealing with mediators of psychotherapy. And we did already some papers, maybe you would be interested in them as well. One is about general Mediators in Psychotherapy, Taubner and colleagues, 2023. And we did also one in externalizing disorders. So if someone is interested can check that. And one on personality disorder is on the way. So hopefully we will see it soon. Today, I would like to present one about mediators of outcome in trauma-focused psychotherapy with adolescents and transition age youth, meaning young adults. We made this differentiation based on some theories and some studies showing different milestones, different developmental stages between these two groups. So I think we all know why trauma would be relevant to investigate and trauma-focused psychotherapy. I was in trauma field for 10 years. That's why this was very interesting for me. We know that trauma is the well-established risk factor almost for any area of individual's life. And it's especially important for adolescents and young adults because we know that almost 50% of lifetime diagnosable mental health disorders starts in adolescence and 75% in young adulthood. And then 4 years later, after receiving PTSD diagnosis, almost half of adolescents and young adults still have this diagnosis. Also, we know that there are we found some tricky results in research of psychotherapy. We see that adherence to specific treatment modality in adolescents doesn't have really a strong impact on outcome. And also we found some contradictory results regarding components that are beneficial. And more we talk about the urge to really reply on the question, what works for whom, which was the goal of the TREATme from the beginning. So when it comes to trauma-focused psychotherapy, we have several psychotherapies that are well investigated. Some of them are trauma-focused CBT, narrative exposure therapy, EMDR. And we have some theoretical papers on possible potential mediators in trauma-focused therapy in general. So the group of authors that are very experienced in trauma therapy did this, Schneider and colleagues, and they suggested some possible mediators, which was our start. So to check if this was tested in studies in trauma-focused psychotherapy. Also, there are some theoretical papers on specific psychotherapies for trauma, such as trauma-focused CBT, but also in adults. But when it comes to adolescents, this is not that clear. There are some specific reviews for specific therapies. But for young adults, nothing specific. So young adults are usually part of the adult group of clients. So, and sometimes some part of the young adults are go along with the adolescents. So we couldn't find really specific data on this group. So the aim of our study was to do narrative synthesis of existing studies on mediators of psychotherapy effects with adolescents and with young adults who experience PTSD or trauma-related symptomatology. So clearly trauma-related psychopathology. We also wanted to check if studies or authors did include some variables such as psychotherapy models, client age and gender, trauma types. Do we have different theories of change in respect to these variables? And we also wanted to check the how much we can, to which extent we can generalize this data. So did we include different groups, different countries in studies so far? So as I said, this was part of the TREATme project. We followed PRISMA guidelines, and this review was registered on Prospero, and we did the PICO question. So we wanted to check if which mediators of change, PTSD, and trauma-specific symptoms could be found in any form of psychotherapy after experience of trauma in adolescents and young adults. Yeah, I don't want to go into detail. Maybe we can discuss that later, but we also made search terms, included all these PICO-relevant words, did the search in PubMed and PsycInfo, and we also did search through the references we found. And this was for general, and then we also excluded those studies that were not about trauma and not about adolescents and young adults. 10 pairs of experienced researchers did this exclusion process, inclusion and exclusion process. At the end, we had 15 studies on adolescents, which investigated, all of them investigated PTSD, but this wasn't needed. We would accept any trauma symptoms as an outcome. Psychosocial, psychotherapeutic intervention, and any form of statistical examination of mediation was accepted. We excluded studies that were done in traumatized samples, but where trauma was, or trauma symptomatology was not an outcome. So having juvenile offenders who did have history of trauma was not enough to be included in our review. So PTSD wasn't the main outcome, wasn't outcome at all. We also did quality and risk of bias assessment. For mediation, to assess the quality of mediation assessment, we followed criteria made by Kasdin and Lemons in 2 papers. And there were 6 questions. We rated the pairs, rated each paper, each study on these 6 questions. If this was RCT, was there control group, sufficient sample size, are there multiple mediators, temporality criteria, was it met, and if there was direct experimental manipulation of the mediator. The second step was to check the quality of study in general. So was that RCT, or was that some other method, for instance, descriptive or control group without randomization. And at the end, we made the groups. We followed the guidelines for evidence-based assessment based on if this is a good quality, satisfactory quality, or unsatisfactory quality of the study. If based on how many of these criteria for each of these assessment was met or was not met. And at the end, we made, for different mediators, we did assessment if there is, which level of evidence-based is met. So strong evidence-based was met when at least 65% of this mediator, of this group of mediators, were significantly associated with the outcome in at least 3 RCTs which had good and satisfactory quality. Moderator evidence was when this study quality was good, satisfactory, unsatisfactory. Any of these options were possible, and insufficient was when there is less than 65% of potential mediators that are statistically significant. We also included non-RCTs, so we followed grade system for non-RCT, but I won't get into detail now. We may discuss that later. So when it comes to results, surprising lack of original studies. So 10 out of 15 studies came from only 4 different samples. 80% were from Western countries, plus 2 from Israel and Palestine. Striking absence of male participants. So no male participants only, and only in 2 or 3 males were present. No study with clearly young adults, and no study with inpatients as a sample. All studies coming from some form of cognitive behavior therapy, mainly trauma-focused CBT and or some form of psychoeducation. So this was also surprising. And when it comes to trauma type, 80% from interpersonal trauma, and PTSD was main outcome in all studies. When it comes to mediators, in 10 out of 15 studies, cognitive mediators were investigated, mainly post-traumatic cognition. There was no significant effect of parent or family-related mediators, which was surprising, especially because these are adolescents. We thought that maybe these variables that were included, parental emotional reaction, depressive symptoms, and dysfunctional post-traumatic cognitions in parents, were not the best representatives of family-related mediators. So maybe this would be different with some other mediators. And what was also surprising is that no emotional, relational, or neurological mediator was tested. Although in those synthesis theoretical papers on potential mediators, these were the categories that were mentioned. And if we look at CBT theory, emotional mediators were also an option. When it comes to gender, age, and trauma type specific mediators, we couldn't find some strong data on that because studies really didn't do this kind of analysis. So when it comes to gender, we didn't have enough studies with males. So we couldn't provide any conclusion on that. When it comes to age, again, no really young adults in the studies. And it was also surprising that there was not as well no adolescent specific mediators in studies. So nothing that would be really in focus for them, for instance, peers or something with the family. Trauma type specific mediators, we tried to discuss them in order to distinguish interpersonal trauma from non-man-made traumas, but still cognitive mediators were the main mediators in both groups. So we can't really say something about different theories of change in these studies. Post-traumatic condition was measured only with interpersonal trauma, but yeah, this is just a choice of cognitive mediator. So we can't really say that there was something in it. When it comes to level of research evidence, moderate evidence was found for post-traumatic cognition, which is in line with adults, studies on adults. Therapeutic Alliance was a promising candidate. We missed one RCT for it. It seems that standards for performing RCTs well established in trauma research. However, problems with testing mediators, especially with when it comes to manipulation of mediator variable, temporality criteria, only one mediator, which can be explained because everything comes from 4 different studies. So there were options to have several mediators in the study, but authors did it like in 4 or 5 studies instead of one with several. Underpowered sample sizes, questionable statistical procedures. As a conclusion, lack of ethnic and gender diversity, we may say, well-established standards in RCTs, moderate evidences for post-traumatic cognition, again, therapeutic alliance, promising candidate, not enough data to discuss group-specific mediators, and we may see noticeable researchers' biases when it comes to selection of intervention and mediators. So they follow their own school and choose the cognitive mediators only. Limitations. So we did general search. So with psychotherapy in general, with mediators in general, we didn't include trauma as a search term. We guess that we wouldn't miss something because general research term would include specific as well, but still we should say that. Some specific databases were not included, such as PTSD PUBs. All these results, we can discuss them only in light of adolescents because we wanted to find young adults, but we didn't. This is not, we don't want to say that other mediators are not significant. We talked about authors' theories of changes and not about mediators of psychotherapy because, yeah, they investigated what they were interested in. Also, representativity and generalizability of the data is limited by degree of diversity. And we also need better study quality in order to distinguish mediators from mechanisms of change. Some implications for praxis we also gave that just go from these points. And this is our group. We did this in 4 years of treatment. So I tried to be quick. Thank you.
Well, thank you very much, both of you, for your presentations. They were great. I think there are a lot of things we could discuss about results and also the limitations you found when conducting the research and conducting the analysis. And so I don't know if there's anyone who would like to. Okay, we have Sami raise hand.
Yes, thank you very much. And thank you for the amazing lectures, both of Vera and Sonja, very informative. I'm a psychiatrist, specializing doctor in Helsinki in Youth Psychiatric Health Center. Two questions actually for Vera. Again, thank you for the informative lecture, Vera. Did I understand well, your research didn't take psychotherapy techniques or specialties into consideration? It was the efficacy in general. Okay. Thank you.
Yes, yes, we had a very wide range of different psychotherapeutic approaches in there. Of course, in the paper you can see a little bit how were they distributed. Not maybe all different approaches were equally present in the results, but yes, that was the search strategy to have it.
Did you put the link in the chat group? I didn't see it. Maybe I'll need to check. Thank you. Second question, because like we're in Finland, so like your Helsinki University, I had the impression that it was kind of like made from United States point of view, like his non-white Hispanic thing. Like, was it made in Finland or was it made like internationally? So that's my question, because here we have like minorities, like different kind of minorities, not white versus white, like just different culture. for minorities. So did I miss that too?
Yeah, we were including studies from all over the world. So any studies, any places were included. But basically, of course, most of the studies are done in Western countries, USA, UK. Are on top whenever you look at the effectiveness studies. But this is a collaboration. We had researchers from I believe 16 different countries and including all possible research from around the world. But yes, Western countries are overrepresented always in psychotherapy research, unfortunately.
Yeah, but actually my question was like, because I was thinking like it was made with Finnish focus, but now I understand better. Thank you, Vera. Thank you very much. Thank you for answering.
Do we have someone else maybe who wants to make any comment, appreciation? I don't know. Okay, Randi.
Yes, thank you, Vera, and thank you, Sonja. I have a question for you, Sonja, because I always find it quite difficult to understand the real difference between mediators and mechanisms of change. So I know you explained it now, but could you elaborate a little bit about that?
Yeah. So mediator is the variable that follows the predictor variable, and that will predict the outcome. So there is this connection, like a triangle, but does not necessarily explain the change. So it doesn't mean to be the part of psychotherapy per se, doesn't explain why psychotherapy works. So for instance, social support can be a mediator of psychotherapy outcome, but this is not related to psychotherapy as a process. But for instance, psychotherapy intervention is a mechanisms of change, because this is something that is really part of the psychotherapy and explains why there is a change in outcome. With this, there are some additional statistical things that needs to be controlled for. In these studies, this wasn't done, and we couldn't really define if something is mediator or something is a mechanism of change. Does it really have something to do with psychotherapy, and does it really explains the change in outcome measure?
Thank you, Sonja. May I also come with a comment to Vera? Yes, because Vera, it sounds quite worrying what you told us about the adherence to the treatment you found both in the RCTs and in the non-RCT studies. So you have studies and the therapists have not actually done what they are supposed to do. Is that so?
Yeah, that is also one of the problems, especially perhaps when you do conduct the research that's out of kind of the original group that's developing some treatment, or kind of from a clinic where you teach and then also do the practice. So the further you go into clinical practice, the more you also have the thing that therapists do more like an integrative approach. So they might not follow fully the protocol on how to conduct that the intervention. But of course, then there's also the thing that adolescents drop out very frequently from therapy. So that's also one thing that maybe you need to adjust a little bit. Also the treatment when you find the alarming signals on that. But you also see that the complete outcome data was missing quite often. So adolescents do drop out in the middle of the intervention also.
Like a comment question. I'll just see if you guys have any reflections, because it seemed like it was great to hear the two papers presented next to each other, because it seems like in the review of the moderators that Vera presented, there was a problem of not being hypothesis driven and fishing for moderators. And then we have like sort of the opposite problem almost, it seems, and on the mediator side, that people are like that researchers are so driven by their particular orientation and hypothesis that that we're kind of not fishing enough, or exploring enough. And I was just kind of curious if there were conversations in TREATme about kind of how we should think about like best practices in designing studies so that they, or whether it is kind of a balance of some studies, the limitation will be that they were too exploratory and fishing, and some, the limitation will be that they were, too limited in their hypothesis focus. And I was just wondering if you could say more about conversations that took place about recommendations for future research.
Well, yeah, maybe I can start and Randi, and so Sonja can continue. Yes, we've been discussing about this quite a lot, across over all the working groups that we have similar findings that we would definitely need to have guidelines on how to do research in general on predictors, moderators, mediators, even for the effectiveness studies for adolescents. What are the measures? Are studies using age-appropriate measures? So we do have also a working group working on that, specifically like the study designs and the measurements on that. So that there's a lot of methodological problems in this, and we are also kind of fantasizing having a next cost action where we can actually build more the guidelines and also implement them in the training of psychotherapists and so on. So there's a lot of work to do on the clinical aspects, but also on the research side. So a lot of discussions were going on and still are going on for these years in TREATme.
Yeah, I think you said the main points.
Yeah, maybe just a comment too, but I think it's a very good reflection of what we find when we want to conduct research, and when we need to go and read papers as clinicians too. Like if we want to learn a little bit more or update our knowledge, I don't know how to really say it in English, but I think it's very challenging because there's not a lot of information, but also it's a lot of diversity in the information we have. And these results are a reflection of this. Like it's a challenge we have as child and adolescent psychotherapists and researchers. Every time we need to do these reviews and analyze the information that we have, having these guidelines for conducting research so that then we can analyze it in a more effective way, maybe it would be really useful, I think. So I don't know if you're actually working in writing guidelines or not, or if it's something maybe for the future research, but I think it's a very interesting point.
Yeah, sometimes I have impression that what we didn't find in these studies is more relevant than what we found, because this is really stronger message. When we started this trauma review, we had so many questions. Is it exposure really good for the adolescents? Can we find something for sexual abuse, particularly something from females? And then we found out that we can't find for any therapy except CBT, and not to mention all other things. So I really hope that we will have success in writing these guidelines, and that they will be applied at some moment.
Yeah, and I mean the lack even within CBT at looking at like emotion regulation as a mediator. Yeah, it's so shocking.
Well, so maybe if we do not have any other question or comment, we can wrap it up.
Yeah, I
Okay?
was gonna say, I don't know what time we said I was going to, but I think our flyer said it was 1 hour.
Yeah, I think so. I think the event was programmed only for 1 hour, so maybe that's also the reason why some people needed to leave. But well, okay. So thanks everyone for coming and joining us. Jordan left a lot of information about the group, and also Randi from TREATme. So we would be glad to see you back in the next journal club, maybe in a month or two. And thank you very much.
Yes, thank you all so much. And the pictures, and also like, I think showing what it looks like to actually do this. It's like, I think sometimes we imagine, oh, you can like quickly do a review, but you know, that it's 4 years of like planning out, you know, how they're going to run and the collaboration. So I think the findings, but I think also hearing about the process is fantastic. Yeah, illustration.
Thank you very much. And if you're interested in reading also the rest of the publications and following the new ones, I just put it our web page there, and of course our Facebook page too. But you can see and read more on the work of TREATme from the web page too. So
Thank you very much.
thank you.
Thank you, everyone. Bye.
Bye.